So I am excited to share with all of you some of my research looking at telehealth for urinary tract infections in emerging adulthood. And let me just start by giving you a little roadmap of my talk today. I'm going to start with a brief overview of my background and how I became interested in studying UTIs among young women. And next, I'm going to walk you through two different studies on access to care for UTIs in emerging adulthood, with a focus on the potential role of telehealth to improve that access. And then I'm going to share with you some kind of future directions for this line of work. And I'm hoping that we're going to have a lot of time for questions and feedback and discussion. And I want to start off by telling you about a young woman that I interviewed whose story really helps to illustrate my kind of personal motivation for this research. And for the sake of anonymity, I'm going to give her the name Sasha. So Sasha is a 23-year-old woman from Los Angeles. She's a college student, a community college student, and she also works part-time or worked part-time at a coffee shop. She developed symptoms of a UTI, but couldn't take time off work to get care. And here is what she told me. She said, I got a UTI and I couldn't get off work and it turned into a kidney infection. And at that point, I couldn't really walk and I got fired. I lost my job because of all of that, because it's against their policy. You can't take off more than a certain amount of days. So since then, Sasha told me that she's had recurrent UTIs and she prefers to get care through online telehealth companies. She has to pay out of pocket for this care, but she feels like it's really the best option given her time constraints. And here is how Sasha described it. She said, now I just go on a telehealth company like GoodRx because I know what it feels like and I have testing strips, so I know how to test for it at home. It's easier to go on and then wait like 4 hours and then get the medication. Otherwise, you spend like 3 days to get an appointment. So Sasha's story really points to the unnecessary suffering and the effects of UTIs, especially in this age group. And hearing about her experience, for me, reinforced this deep belief I have that everyone should have access to timely healthcare when they need it, including UTI care. And this value has guided my career as a social scientist, working to improve access to quality healthcare, especially for young people. So prior research tells us that Sasha's experience is not all that unique. UTIs are one of the most common infections, leading to about 10.5 million outpatient visits each year in the US. And sexually active young women are especially affected. So about 1/3 of women are treated for a UTI by age 24. And we know that these infections cause pain and interfere with daily life, including school, work, and mental health. And if not treated promptly, UTIs can progress to serious conditions like the kidney infection that Sasha had, which makes timely care really important. At the same time, emerging adulthood, which includes ages 18 to 29, is a key time when a lot of young people start managing their own health care, but many face challenges in doing this, like not understanding how insurance works or losing coverage when they age out of their parents' insurance plan. In addition, young people under 25 have the highest rates of STIs, sexually transmitted infections, and may also face more stigma and shame around sexual health, which can make them less likely to seek care when they need it. And before diving into the specific studies in this area, I thought I would share just briefly a little about my background and prior research. My path here to the CAIRIBU network, I think is a little bit unique, and I think it helps provide some context for the work that I'm going to be presenting. So my prior research has really centered around understanding social determinants of youth access to sexual and reproductive health care. And as Alex mentioned, I received my doctorate in public policy and sociology from the University of Michigan. I don't know if there's anyone from Michigan on the call today, but I feel inclined to say go blue. Uh, I completed training there at Michigan in advanced quantitative analysis and survey methodology, and also population science. And then after finishing my doctorate, I really wanted to use my skills to specifically focus on programs and policies to improve youth access to sexual and reproductive health care. And so that led me to UCSF and the Institute for Health Policy Studies, conducting research and evaluation of California's state family planning program, which is called Family Pact. And to give you an example of this kind of work, we did a mixed method study to identify the factors that were driving a decline in youth participation in the program at that time. I also built on my doctoral training in population science to investigate trends and disparities in youth access to reproductive health care. For example, we did one study that documented that adolescents living in rural areas have less knowledge of where to receive family planning services, and they're less likely to use family planning services than those in urban areas. My prior research has also studied how cost and insurance coverage impact youth access to care. For example, we did a qualitative study that identified gaps in health insurance literacy and how these gaps can impede access to care, specifically in times when young people are changing insurance coverage, that ends up being a time when there's some gaps in access to care. With my colleagues at UCSF, we've also fielded large cluster randomized controlled trials testing interventions to improve youth access to sexual and reproductive health care. One of the trials, we evaluated a new program that integrates in-person and technology-based sexual health education for vulnerable young people, adolescents, and this program demonstrated that it was effective in increasing access to sensitive services. We saw an increase in use of contraceptive services, STI services, and behavioral health services. And then in the pandemic, I launched a new line of research focused on youth access to contraception through telehealth. And one of these studies was a qualitative study with young women 18 to 25. And we heard through this study how many of the young women that we spoke to said they'd prefer telehealth for contraception because it's more convenient, it saves them time, it feels more private, and some said that they felt that the quality of care they would get would actually be better through telehealth. And surprisingly, in this study, which was during the pandemic, COVID infection didn't really come up in the interviews. It was really around convenience and access to care overall. So these findings sparked an interest for me in how telehealth can be better leveraged overall to meet young people's broader needs across these intersecting areas of genitourinary, sexual, and reproductive health care. And through the UCSF Urologic Epidemiology K-12 Career Development Program, say that 4 times fast, I've been able to expand my work to include UTIs and understanding the role of telehealth in improving access to UTI care specifically. And that is the work that I'm going to be sharing with you today. So telehealth has tremendous potential to address a lot of barriers that have been around for a long time in our healthcare system, like transportation challenges, long waits for appointments, and concerns about privacy. And we saw a really huge shift during the pandemic. Telehealth use went up by 154% in just 1 year, from March 2019 to March 2020. And as we all know, during that time, video and phone visits became really essential, not just for safety, but for making sure that care was still accessible. And then even beyond the pandemic, telehealth has continued to play an important role. And for a lot of people, it's simply more convenient and more private. Importantly, we have research that shows that managing uncomplicated UTIs through telehealth can be safe, effective, and efficient. And even though telehealth has this potential to improve access, especially for conditions like UTIs, telehealth equity is still a big concern. So specifically, telehealth may be underutilized by young adult women. We have some national data from the Census Bureau that show between 2021 and 2022, young adults had the lowest rates of telehealth use for any group. That was 18% of adults 18 to 24 using telehealth in the last month, compared to 23% for adults overall. And in our own research, we also found low telehealth use in this age group. We found during the pandemic that just 6% of emerging adult women said they received their contraceptive method through telehealth. And in addition, we found evidence of disparities in telehealth access by basic needs insecurity, food insecurity, housing insecurity, and also by health insurance coverage. And these same challenges are likely to affect telehealth use for UTI care, but no studies had specifically examined telehealth for UTI care in this age group. And my research through the K-12 is really aiming to fill that scientific gap. So I built my K-12 research on the infrastructure of a study called REACH Youth, which stands for Reproductive Equity and Access in College Health. This is a cluster randomized trial in 29 community colleges in California and Texas, which are shown with the little stars on the maps here. And the trial is testing an intervention to improve access to contraception. With this study, we enrolled over 2,000 students in California and Texas, and students were eligible to participate if they were first-year college students, ages 18 to 25, assigned female at birth, gender inclusive, sexually active, and not pregnant or wanting to become pregnant. And recruiting from community-based settings is a real advantage for this work because it allows us to include the people who are maybe facing the greatest barriers and not making it to a clinic. After enrollment, we followed students over time and collected online surveys for 5 years. This is a community engaged research. We've integrated community feedback throughout the research process with a youth and community advisory board. So starting in May of 2024, we added a module on UTIs to each of the follow-up surveys. And this module included questions about recent UTI symptoms, barriers to care, self-management of symptoms, what their experience with UTI care was like, their perceptions of access to care, and preferences for where and how they would receive care. I'm happy to talk more about the development of the survey module. I really love survey methodology, so I would happily talk to anybody about surveys all day long. But we pilot tested the survey with 25 participants. We did cognitive interviews with those participants just to get feedback on how they were interpreting the questions. And that was a really rich and fruitful process. I wanted to share some sample characteristics to give you a better sense about who is in this study population, which is unique and important. So 99% of these participants were cisgender female, and most of them were ages 19 to 24 at the time of the UTI survey they completed. And this sample is really racially and ethnically diverse, with the largest group identifying as Hispanic, which is reflective of who the community college populations are in these states. Half of them speak a language other than English at home. They're also disproportionately socioeconomically disadvantaged, which again is reflective of community college students. Over a quarter reported food insecurity. Nearly 2/3 are first-generation college students. 1 in 5 were uninsured, and 1 in 3 said they lacked a usual source of care. And in terms of their UTI history, we had 1/3 of them who had reported a prior UTI diagnosis. So the first study that I published from this data looks at perceived barriers to care for UTIs in this emerging adult population. And this paper recently came out in the Journal of General Internal Medicine. I feel like I should give a plug for everyone to pull up the full article and read it. So why focus on perceived barriers? Well, research shows that when women perceive barriers to care, they're more likely to delay or skip getting care. And that's why understanding exactly what are the perceived barriers is important so we can do something about them to ensure timely, appropriate care. There have been several qualitative studies from Europe that have explored barriers to UTI care, but this is really the first study to look at how these issues play out in the US and particularly among emerging adults. And it's important to understand the specific challenges of UTI care in this key transition period and also in our particular unique US context. So this work is drawing from the Social Determinants of Health framework, which emphasizes the role of social, economic, and environmental conditions in shaping access to care and health outcomes. This is kind of bread and butter for social science health research, this social determinants framework. And even though social determinants are really widely recognized as important drivers of health outcomes, we still have really limited research on how they shape access to UTI care. For example, there were 2 studies in the UK that asked women about their UTI symptoms and care seeking, but these studies didn't look at how experiences vary by background. There's a small study in the US that found non-English speaking patients received less education about UTIs and had lower knowledge, suggesting that there are some real inequities to care here in the US. And so we designed this study to help fill those gaps by looking at perceived barriers to UTI care and how those barriers vary by social determinants of health. And this research is also guided by the Levesque model of healthcare access. So this is a model that defines access as the opportunity to reach and obtain appropriate healthcare services when there is a perceived need. And I really love this model because it outlines the steps that patients navigate, breaking it down from initially recognizing the need for care to then fully being able to engage in the visit. And this framework has been valuable for understanding how specific digital solutions like telehealth can either support or end up creating more barriers to accessing care within health systems. So to measure perceived barriers to UTI care, we developed a set of 14 survey questions. We introduced them with the prompt. I'm just going to read it to you so you understand kind of the context of this data. The next questions ask about your ability to get medical care for urinary symptoms, such as frequent or painful urination, even if you have never experienced them. Please indicate if you agree or disagree with the following statements about getting medical care for urinary symptoms. So these were based on barriers that have come up in the qualitative research. And then we also designed the items to really align with that Levesque model of healthcare access, focusing on different abilities that people need in order to access care. And you can see those abilities in the first column and then a sample of the wording of a question on the right. For example, to measure perceived, rather the ability to perceive, we said, I would know if I needed to seek care for urinary symptoms. And so for the analysis, we created binary variables equal to 1 if they reported a barrier. And then we also created a composite measure by summing the 14 dichotomized items. So higher scores would indicate more barriers to care. And in terms of the participant characteristics, we were interested in key factors linked to healthcare access, whether somebody was uninsured, and whether they reported that they have a usual source of care. We also considered a range of sociodemographic characteristics like age, race, ethnicity, the language spoken at home, which state they lived in, California or Texas, and whether they were food insecure. And then we also considered a prior UTI diagnosis. We use descriptive characteristics to understand what were the most common barriers, and then multivariate mixed effects, logistic and linear regression to really predict the most common barriers to UTI care, as well as the number of barriers. And our analytic sample had just over 650 participants. So on average, we found that participants reported 4 out of 14 barriers, and these barriers spanned multiple dimensions of access to UTI care, starting with that ability to recognize that they had a need for care. 16% of participants said that they wouldn't know when to seek care for UTI symptoms. And then as far as the ability to seek care, more than half said they were afraid of hearing bad news. 42% were concerned that their parents might find out about their symptoms. 1 in 3 worried that their symptoms might mean that they had an STI, and then 1 in 4 were worried about their privacy. Barriers to reaching care were also common, with 46% anticipating appointment delays and 40% feeling that they were just too busy for appointments. And some participants weren't sure where to go for care, and 17% had concerns about physically getting to a clinic. Cost was also a major issue, which I'm sure is not surprising to anybody on this Zoom call. Nearly half reported that they would worry about the cost of UTI care. And then many participants were also concerned about the visit itself. 1 in 4 said that they would feel uncomfortable talking about their symptoms with a provider, and 20% worried about being judged by a provider. 17% said that they didn't fully trust healthcare providers overall. And then 17% said that they would have a hard time communicating with a provider. Okay, so now I'd love to look at the results of our multivariate models, looking at the most common perceived barriers to care. And I know that there is a lot going on this slide, so I'm going to walk you through some key findings here. So first off, younger age was associated with more concerns about receiving bad news, about having an STI, and parents learning about their symptoms. Racial and ethnic group was also associated with these barriers. Specifically, Asian and Pacific Islander participants had higher odds of concerns about STIs and parental privacy than Hispanic participants. And they were also more likely to be concerned about cost than Hispanic participants. We also found that socioeconomic disadvantage was strongly associated with perceived barriers. Food insecurity really stood out. It was associated with almost all the barriers that we looked at, with adjusted odds ratios ranging from 1.43 to over 2. And then in addition, we found that uninsured participants also were more likely to expect delays in getting an appointment, and not surprisingly, nearly 3 times more worried about the cost of care. And then finally, we found that participants who said they lacked a usual source of care also had higher odds of expecting appointment delays and cost-related concerns. And then when we looked at this as predicting the number of perceived barriers, the results were consistent. Specifically, younger participants, Asian Pacific Islanders, and those who spoke a non-English language at home reported more barriers to UTI care compared to others. And then we also found that those experiencing food insecurity, uninsured, and lacking a usual source of care face significantly higher numbers of barriers. So what do we take away from this? As we kind of started out, UTIs are very common, especially among sexually active young women, but many of the young people in this study reported a lot of perceived barriers to accessing care for UTIs. And these barriers occur at every step that a patient must navigate in order to get care for a UTI. The most common barriers that we saw, like hearing bad news, worry about potentially having an STI, fear of your parents finding out, these all kind of highlight the stigma and sensitivity around UTIs in this age group. Cost and long wait times were also major barriers. These are common to many, types of healthcare in the United States healthcare system. Emerging adults in particular can find it really hard to navigate this complex, expensive system on their own, especially if they don't have health insurance or a usual place that they're going to get care or other kinds of support. And our findings also show clear disparities in access to UTI care. Barriers were, more common among younger people, Asian Pacific Islander, the uninsured, people without regular health care, those facing food insecurity. And so tying this back to telehealth, expanding telehealth can really help to address the specific barriers that young people face when seeking care for UTIs. For example, asynchronous e-visits eliminate the need to schedule appointments, which could really help reduce the delays that nearly half of these participants anticipated. And this kind of flexibility could also help those who said they feel too busy to have an appointment. Additionally, telehealth can offer greater privacy, which is an important factor since many participants worried about their parents finding out about their symptoms or feeling too embarrassed to discuss their symptoms. Being able to engage from the comfort of their own home might make young people feel more comfortable seeking help for UTIs, as well as other sensitive services. Okay, so as we've been talking about, many of these common barriers that they reported could be reduced through telehealth, but we don't really know if young people prefer to use telehealth or whether they even have access to telehealth for UTI care. And so that is the next question that we asked with this data. And this is data that I presented at the SUFU winter meeting. In case it looks familiar to any of you, I can't really see everybody and whether I recognize you from SUFU, but there you have it. All right. So we know that access to care isn't just about whether services exist. It's also about whether they work for the person who needs them. So if the modality of a format of care feels inconvenient, uncomfortable, or unfamiliar, young people may avoid seeking help altogether, even if the care is technically available. And different modes of UTI care, like in-person visits, video calls, phone consultations, e-visits, they each have their own benefits and drawbacks. For some people, they may really prioritize the privacy and flexibility, while others might value the opportunity for a more in-depth, in-person discussion or like a physical exam. And so that's why it's important to understand how young people perceive the options available to them and how they prefer them. And aligning care with those preferences can support earlier care seeking, better engagement, and ultimately potentially improved health outcomes. So understanding perceived access is important because it shapes whether people feel like they can realistically use a care option, even if the option is technically available. For example, somebody who lives near a clinic may feel like they can't go because of work or maybe their privacy concerns. And also, if certain groups of young people don't view specific modalities as feasible, that could reinforce what we know are existing disparities and delay timely care for a UTI. But we, to date, don't have studies looking at preferences and perceived access to UTI modalities in this emerging adult population. And so here we are. Our analysis is looking at these two outcomes, whether they prefer telehealth for UTI care, which could include a phone, video, or e-visit, and whether they thought that it would be difficult to have a telehealth visit for UTI symptoms. Again, either phone, video, or e-visit. And I am happy to talk more about these outcomes and how we measured them and in the Q&A. For the predictors, we looked at a measure of whether they perceived difficulty having an in-person UTI visit. And then we also looked at the set of participant characteristics, the same set as the last analysis of perceived barriers that you see here. Our analytic approach used separate multivariate mixed effects logistic models predicting telehealth preference and perceived difficulty with telehealth UTI care. And it included the full UTI survey module sample of over 900 individuals. So overall, we found that most participants preferred an in-person UTI visit. However, 1 in 4 said that they would prefer a telehealth visit. And among the telehealth options, e-visits were actually the most preferred mode. In total, 13% of participants said that they preferred an e-visit. And I'm realizing that I regret at the beginning when I introduced e-visits, I didn't define that. And some of you may be wondering, what exactly is she talking about with an e-visit? So an e-visit refers to an asynchronous visit, and this is something that we did define in the survey so participants would know exactly what we were talking about. So an asynchronous visit where an individual answers a set of questions about their symptoms online and hears back from a provider later. So now let's look at results of the multivariate model. This figure is showing predicted probabilities based on a model with all covariates predicting a preference for telehealth. So we found that those lacking a usual source of care were more likely to prefer telehealth. We also found that those who had a history of UTI were more likely to prefer telehealth, and they may feel more comfortable kind of recognizing their symptoms and forgoing in-person care, resonating back to Sasha's story, where she said, I recognize the symptoms. I feel comfortable going to GoodRx or another online company. Younger age was associated with a telehealth preference, although the dichotomous variable that I'm showing here didn't quite meet the threshold for statistical significance. Okay, so now let's turn and look at findings on access to telehealth UTI care. Overall, we found that most participants perceive telehealth UTI visits and in-person UTI visits as easy or very easy. So across all modes of care, easy or very easy. Phone visits actually had the highest combined difficulty rating, with 23% of participants perceiving phone visits as being challenging. And about 29% of participants said that they would have difficulty using at least one mode of telehealth, phone, video, or e-visit, while the majority, 71%, found all these telehealth modes as easy to use. And these findings highlight that most people are comfortable with telehealth, but a significant minority said that they would face challenges with certain telehealth modalities. Here is, again, showing predicted probabilities based on a model with all covariates, looking at perceived difficulty with telehealth UTI care. We found that younger women and those experiencing food insecurity were significantly more likely to report limited access to telehealth for UTIs. And these findings align with our previous research with this age group looking at access to telehealth for contraceptive care. As we would expect, we found that participants who reported difficulty with in-person care were more likely to prefer telehealth. However, we also found that they were more likely to report challenges accessing telehealth. So these findings together suggest that many young women prefer telehealth for UTI care, but they also face a lot of barriers to accessing it. In addition, we find that access to telehealth is not equitable. It's more limited among those who are younger, experiencing food insecurity, and have a harder time with in-person visits as well. So this creates this disconnect where those who would benefit potentially the most from having telehealth often face the most obstacles to actually using it. And these dynamics can have implications for how and when and whether young people are seeking care, as well as the outcomes of delayed UTI care. Okay, so if you'll allow me to wear my hat from the health policy angle, drawing from this data, I just want to add a few recommendations specifically with youth in mind. And the first is that broadly, we need to expand youth access to telehealth for UTIs. And more specifically, we should prioritize policies, programs, and interventions that address some common barriers among youth, like insurance coverage of telehealth, availability, and privacy concerns. Here in California, I want to give you an example of a policy that does this well, that does try to address these barriers. In AB 32, this was a state law passed in 2022. This permits Medicaid providers to establish a new patient relationship using a phone visit when it's related to a sensitive service, which does include UTIs. And I would argue that we need more state policies like this to allow for greater flexibility with telehealth. We also need more youth-friendly outreach and education about telehealth. Outreach and education is needed to raise awareness where telehealth is an option. And also we need education and outreach to ensure that it is accessible to all students. And for my last recommendation, we need to invest in clinic infrastructure to ensure that telehealth services are available. And we also need community-level approaches to address community-level barriers. So as an example, programs on college campuses can provide education about telehealth, along with information about local health centers that are offering this care. Okay, so these are two examples of studies using the survey data, and I want to highlight briefly some additional analyses that we're conducting with this data to try to further understand how telehealth can expand access to UTI care. So first, we're looking at specifically young women's interest in those asynchronous e-visits for UTI care and concerns that they may have about this particular option. We're also looking at the reasons why some young women choose not to seek care when they have UTI symptoms, along with use of home remedies and home testing. If you've ever done a search for UTIs on TikTok, there is a real plethora of some inventive home remedies out there. Third, we have a subset of participants who had been diagnosed with a UTI in the past year. And with this subsample, we're comparing telehealth and in-person visits to understand differences in their perceptions of how accessible, how convenient, how affordable, and overall quality, how satisfied young people were with those visits. And then we're also investigating how diagnostic practices differ between telehealth and in-person visits, specifically focusing on UTI and STI testing, and also whether there was a sexual health history taken in the visit. In addition to the survey study, we're also doing a qualitative study to try to really better understand how emerging adult women navigate UTI care across these different visit modalities. We've interviewed 25 women who had a UTI in the last year to understand what the barriers and facilitators were to accessing care at each step in the process, from recognizing symptoms all the way through engaging in the visit. And these interviews have provided really rich, kind of detailed insights into their UTI care experiences. And our goal with the analysis, which is currently underway, is to be able to identify some concrete recommendations to improve access and quality of UTI care, especially for those who are getting care through telehealth. And then finally, I want to tell you about some future directions for this work. So first is a study that we are doing about how adolescents specifically learn about and seek care for UTIs. And this is a topic that is really, if there's very little research on UTIs in young adults, there's even less that we know about UTIs with adolescents. So this is a supplemental study to an ongoing randomized controlled trial of an adolescent sexual health intervention that we just launched. We are collecting baseline survey data from adolescents who are being recruited across multiple states. Ultimately, the goal for the RCT is 1,200 adolescents. So hopefully, if all goes well, with that trial recruitment, we'll have data from a pretty diverse group of 1,200 adolescents about UTIs. And the survey, the questions that we've included in that cover a wide range of factors, whether youth have received formal education about UTIs, if it's something they've ever talked to their parents about, searched online for information, or if they've received UTI care. And our goal is to use that data to identify who has access to UTI information and services in this age group and what gaps remain among adolescents. So another planned study, I've submitted a proposal, another knock on wood that this will move forward. But in this study, we're going to use EHR data from 2 major San Francisco healthcare systems. And the goals here would be to identify factors linked to telehealth use for adolescent and young adult women with genitourinary symptoms. And then to compare diagnostic testing rates, both for UTIs and STIs by the type of visit. This is something that we can do in our survey data, but at a much smaller scale. So to be able to look at this across 2 different diverse health systems would be really exciting. And we're proposing to also conduct, as part of this work, interviews with providers, being able to identify providers that are using more telehealth versus in-person care, differences in diagnostic testing, and so to select those that we interview to understand the barriers and facilitators to both telehealth use and testing in this population. Another area of interest for me is developing and testing educational materials to help youth access care. So this slide is showing you part of an educational tool that we developed to raise awareness about telehealth as an option to get contraceptive care. It's showing you one part of the tool. And we did pilot testing, which showed that this tool improved youth knowledge about telehealth for contraception specifically. There's a real need for specifically youth-friendly education about UTIs in general, but also about telehealth for UTI care specifically. So if you have any ideas for potential funders for this kind of work, let me know. So just wrapping up, I want to acknowledge my team of K-12 mentors. They are wonderful. They each bring a really important interdisciplinary perspective to this work. It's been incredibly valuable. And I also want to acknowledge the wonderful collaborators I have on the Reach Youth study, both at UCSF and also UT Austin. And I'm also just really grateful to our youth and community advisory board members, as well as all of the participating sites. And if you are potentially interested in talking about shared research interests or future collaborations, I welcome you to reach out. Here's my email address, and looking forward to hearing about that in our conversation as well.